Can you hear me? Those who have joined, can you hear me?
Yes, doctor.
Okay. Can you still see my slides?
Yeah, it's clear.
Yes. Are they slideshow or are they small?
No, it's slideshow.
Slideshow. Great. So, large tongue. Of course, the patient will not tell you in the symptoms, my tongue is large. Some may tell you, but most patients, they will tell you, my speech has changed. I have like, I feel that my tongue is filling my mouth, so I cannot speak properly like I used to. Okay? So when you examine, you will find the tongue is very large. Of course, hirsutism and thick, greasy skin. The hirsutism occurs in women. By definition, hirsutism means growth of terminal hair in androgen-dependent areas in ladies. What are these androgen-dependent areas? Who can tell me?
Beard والmustache والpubic hair والaxillary.
No, the pubic hair is normal. It's not an androgen-dependent areas. I mean, it's not considered one of the androgen-dependent areas because it is caused by adrenal androgens. Okay, not by excessive androgens. But the other areas like you mentioned, beard, mustache, the sideburns, the upper chest, front and back, and the upper arms, and the lower abdominal triangle. All right, and the upper thighs, upper medial thighs, front and back. These are the androgen-dependent areas. Okay? You never say a man has hirsutism because it is normal for a man to have hair on his body, but it's not normal for a lady to have hairy body. Okay? Now, why does the skin appear thick and greasy? Thick because there is skin thickening as part of soft tissue enlargement. But why is it greasy? Oily. Why? Who can tell me?
Because there's hypertrophy of the sebaceous glands.
Yes, very good. There is hypertrophy of the sebaceous glands in the dermis as part of soft tissue enlargement. Great. And the patient, you will find spade-like hands and feet, زي الجاروف. Okay? The patient, she may have complained of tightening of the rings. My wedding ring was too tight, so I couldn't put it off with soap. So I went to the jeweler and he cut it off my finger. Okay? Carpal tunnel syndrome. This is a symptom. It can cause pain and tingling in the hands, but if it wasn't complained of, you as a physician, you have to look for in the form of a sign. You have to perform Tinel's and Phelan's tests. Maybe I will show you a video later on how to elicit these. Okay, and the patient may have colonic polypi. How do we suspect the presence of colonic polypi in an acromegaly patient? Who can tell me? Or even how can we screen for colonic polypi in acromegalic patients? Who can tell me?
Colonoscopy.
Sorry?
Colonoscopy.
Yes, it's an invasive test, but you can actually check occult blood in stools. If it is positive, then you do a colonoscopy. Okay? Visual field effects. Of course, the patient may complain of those, but most probably they won't complain. But you, as a physician, you check the visual field of the patient by confrontation test. And I'm sure all of you know how to do it. Galactorrhea, as I mentioned, it can be spontaneous. You look at the patient's breasts and you find milk coming out of the nipples, or it can be expressible. If you squeeze the breasts, the nipples from side to side, milk will come out. Of course, and when you measure the blood pressure of the patient, you will detect hypertension. You can find edema of the lower limbs. The patient may even present in heart failure. There is arthropathy, like there can be swelling of the joint with synovitis, with crepitus, okay? And if you examine the the muscle power of the shoulder and pelvic girdle muscles, you will find definitely proximal myopathy. You need to check the muscle power of the flexors, the extensors, the abductors, and the adductors of the shoulder and the pelvic girdle, okay, and the hip joint. And of course, you can also check urine for glucosuria when the patient is suspected to have diabetes mellitus. Okay? Until here, anything that is not clear? Am I going too fast?
No, doctor, it's clear.
Okay. Let me continue. So here I have wrapped up all the clinical manifestations in an acromegalic patient. A patient will present with headache, with coarsening of the facial features like supraorbital bulging, frontal bossing, enlarged nose, enlarged tongue and lips, enlarged ears, and prognathism with separation, interdental separation, enlarged tongue, as I mentioned, the thyroid may be enlarged. There you may find skin tags, particularly on the neck and on the upper chest, front and back. And these are in particular very bothersome for ladies. Anything that has to do with the external appearance is bothers a female patient. And of course, you will find galactorrhea, and there is increased sweating with oiliness or greasiness of the skin. There is high blood pressure with cardiomegaly. There can be hepatomegaly, nephromegaly, splenomegaly as well, enlarged colon with polypi, enlarged hands and feet, and carpal tunnel syndrome, and osteoarthritis. All right? So far, so good. So here, this is what I meant when I told you to check old photographs of a patient. You see, this is a young gentleman. He was very handsome at one time, but then over years, you see, he started developing acromegalic features. The patient himself may not notice. So this is why, in most cases, the condition is diagnosed very late. Okay, you see, this is a lady. She's called Mary Ann Bevan. She was telling about herself, I am the world's ugliest woman. You see, she looks almost like a man. She's very ugly. I wonder if her husband divorced her or not. Okay. A lot of social problems can occur in female patients with acromegaly. All right. I have seen once a patient whose husband divorced her because she became ugly and because she developed hirsutism. Okay, so this is something very depressing for a patient. And these are the palms of or the hands of an acromegalic patient. You see the grid lines in the picture are 1 centimeter apart. You see the palms or the hands of this patient are spade-like, okay, زي المجروف. And the fingers appear sausage-shaped, like زي سوسيس. They are broad. They are broad. They are not broader than taller. You see, okay? And here the soft tissue of the thenar and hypothenar eminences is very thickened, very much thickened. Here you can see this here, the hand with the watch is the hand of the physician, okay? The physician he is a male, he has a rather big hand, size 6.5, and this is the acromegalic patient, you see, with the full-blown picture of coarse facial features, large nose, large lips, and so on. You see the hand of the physician as if it's floating inside the hand of the patient, okay? Very important, very significant. And you see, this is another acromegalic patient. The patient's hands are spade-like with wide sausage-like fingers and increased soft tissue in the thenar and hypothenar eminences, okay? Again, spade-shaped hands in acromegalic patients with sausage-shaped fingers, okay? And here there is also not only increased size of the hands, but also increased size of the feet. You see, in particular here, the heel, the soft tissue of the heel is particularly enlarged. Here you don't say there is increased heel pad thickness because increased heel pad thickness is a radiological sign, like I'm going to show you later on. Okay, but here you can say the foot is enlarged with increased soft tissue, particularly over the heel. Okay, and here you can see a patient with acromegaly having an elongated face with prominent supraorbital ridges, prominent zygomatic bones, a large nose, large ears, and thickened lips. And here again, you can see again in front view and inside view the facial features of acromegaly. And here you can see these are the skin tags. A female patient would tell you, I have increased nevi. Hasanet. No, these are not nevi. These are skin tags. They may be sessile or they may be pedunculated, right? But here they are rather big. Okay, so here you can see again a large nose, large lips, large ears, prominent zygoma, prominent supraorbital ridges. Okay, and here in addition to prominent supraorbital ridges, prominent zygoma, large nose and large ears, here you can see the prognathism is evident, you see. But you need to do, this patient again has prognathism with a large nose, large ears, and thickened lips. But you need to do this maneuver. Please show me your teeth in order to be able to detect prognathism. Here, obviously, the lower incisors come to lie in front of the upper incisors, and the patient has also interdental separation. All right? Again, prognathism, interdental separation, not so obvious as in the previous slide, large nose, very apparent, and thickened lips. Okay? And here you can see large ears and a large tongue in an acromegalic patient. You see here, this is typical macroglossia, very large tongue, in addition to the obvious acromegalic features. Okay? Now, this is bitemporal hemianopia. This is the normal visual field. Now, if I'm looking straight ahead like that, I can appreciate what's on the right side of my visual field and what's on the left side of my visual field without having to turn my face or my eyes. This is normal in all of us. But once a pituitary tumor started compressing the optic chiasma, it actually, the visual fields will suffer. It depends on whether it is compressed from the back, from the front, or from below. So it starts to contract from both temporal sides, what we call bitemporal hemianopia. It's as if the patient is looking through a tube. Okay? Now, anything that is not clear till now? Any problem so far?
No.
Okay. Am I going too fast or too slow?
No, تمام.
Okay, now coming to the important imaging in acromegaly, we have plain x-rays. This is the normal skull x-ray in lateral view. Of course, here the focus is on the sella turcica. Here you can see this is the sphenoidal bone. These are the anterior clinoid processes, the sella turcica itself, the floor of the sella turcica, and the posterior clinoid processes with the dorsum celli, and the floor is intact, not eroded. And here is air inside the sphenoidal air sinus. Okay, normally, in all of us, the pituitary, the sella turcica should accommodate only the tip of the little finger. Okay, the tip of the little finger. It's as small as that. Okay, but look at the plain X-ray skull lateral view in acromegaly. Here, first of all, you will find thickening of the skull vault, right? And you will find hyperpneumatization of the frontal and maxillary air sinuses. You will find ballooning of the sella turcica, okay? It accommodates more than the tip of the little finger. And there may be also erosion of the dorsum celli, erosion of the anterior or the posterior clinoid processes, and even erosion of the sellar floor. And here you can see mandibular prognathism. Okay, is it clear? Again, mandibular prognathism, see? Very obvious, okay? Type. If you do a plain X-ray on the hands of a patient with acromegaly, you will find there is increased bone density with epiphyseal widening. Why is there epiphyseal widening? Who can tell me? Yani the joint space appears to be larger. Why is that? Who can tell me? Huh? Can you still hear me?
ممكن effect of growth hormone على الكارتليج على
Yes,
الكارتليج.
yes, the growth hormone enlarges the cartilage. Cartilage on plain X-ray appears black. So it appears as if the joint space has actually widened, okay? There will be tufting of the terminal phalanges. You see here, they appear mushroom-like. Normally they are just very small, but they appear like a mushroom, okay? And then, like here, you see, they are mushroom-shaped. You see? This is what is meant by tufting of the terminal phalanges. Again, this is not a clinical sign. This is a radiological sign, okay? And here is a plain X-ray of the left foot of a patient with acromegaly showing increased heel pad thickness. You see, this is a radiological sign, okay? The heel pad thickness normally is less than 21 millimeters. If it is more than 23 millimeters, it is diagnostic, okay? If it's more than 21 millimeters, it's suspicious, but if it's more than 23 millimeters, you can actually measure it with the tape measure or with a ruler. It is diagnostic of increased heel pad thickness, a radiological sign seen in acromegaly, okay? Now coming to the MRI of the sella turcica. This is a coronal MRI of the sella turcica. Please, whenever you get an imaging procedure, try not to look at the pathology at the first thing, no, but just describe what it is. Whether it is an MRI or a CT, whether it used contrast or without contrast. In case of MRI, whether it is T1 weighted or T2 weighted images, okay? And which cut, coronal or sagittal or axial, okay? Very important. So these are two films of a pituitary an MRI of the pituitary gland, coronal cut, okay? T1 weighted image. Why did I say T1 weighted image? Because the CSF here appears black. In T1 weighted images, the CSF always appears black, while in T2 weighted images, CSF appears white, okay? So let's revise the anatomy again. This is the air in the sphenoidal air sinus. This is the pituitary gland or the sella turcica. Here is the cavernous sinus on the right side, the cavernous sinus on the left side. And here the patient has taken contrast. How do I know that? Because intravenous contrast, because you see the pituitary is whiter in color than normal. And inside the pituitary, there is this hypointense lesion or a filling defect. Also, you can notice that the upper border of the pituitary is convex, and the pituitary stalk, instead of being central, it is deviated to the left. And here is the optic chiasma, okay? And again, here is another coronal pituitary MRI showing a left-sided lucent intracellular microadenoma, and the pituitary stalk is slightly deviated to the right. It should have been central like that, but it shifted to the right. And here is the optic chiasma. It's not affected. And of course, also the upper border of the pituitary, instead of being either flat or concave, it became a bit convex. So these are pituitary microadenomas. By the way, just by looking at the imaging technique, you cannot say whether this is a growth hormone secreting microadenoma, a prolactin secreting microadenoma, or something else, okay? So in general, in endocrinology, we do first the laboratory or the biochemistry, followed by the imaging, in order not to miss any diagnosis, okay? Now, these are two pituitary MRIs. This one is in coronal section. It's a T1 weighted image because the CSF is black, okay? And this one is a sagittal section. Again, it's a T1 weighted image because the CSF appears black, okay? Now let us look at this picture on the left-hand side. It shows the sella turcica ballooned by a very large macroadenoma extending paracellularly into the left cavernous sinus and supracellularly compressing the optic chiasma. Okay, and here the pituitary macroadenoma is even larger. بطيخة. It has invaded upwards. It has invaded the optic chiasma, the hypothalamus, and even reaching till the area where the corpus callosum is. Very, very large. Okay. Anything difficult so far? Any problems?
No, doctor, it's clear.
Okay, great. And here is another pituitary macroadenoma in acromegaly. Here it's a pituitary MRI, sagittal cut, T1 weighted image because the CSF appears black, with contrast showing a very large pituitary macroadenoma encroaching on the optic chiasma. Okay. And here is a pituitary MRI in coronal section, T1 weighted image because the CSF is black, showing a macroadenoma extending to the right cavernous sinus. Okay, but sparing the optic chiasma. All right. Now let's shift to carniopharyngioma. This is actually the most common pituitary tumor in children, but it may present at any age. The youngest patient with carniopharyngioma I have seen was a 10-year-old boy. Actually, his presentation was very tragic. At the age of 4 years, he started developing what was diagnosed as nocturnal enuresis. Okay, but actually he was also complaining of headaches. And he started to develop declining vision until he became bilaterally blind. So I don't know how he came to visit us at the endocrine unit. We discovered a short boy. At that time, he was 10 years old. He was very short for his age. And he was bilaterally blind with bilateral fixed dilated pupils. And he had pan-hypopituitarism with diabetes insipidus. So it turns out that this poor boy had a craniopharyngioma all the time, presenting with diabetes insipidus, and he was erroneously diagnosed as having nocturnal enuresis, and he has been neglected for 6 years until he became bilaterally blind. A tragic case. Okay. It is usually a cystic hypothalamic tumor, and it's often calcified, arising from Rathke's pouch, and it often mimics an intrinsic pituitary lesion. So this is how it looks like on plain X-ray of the skull. The middle cranial fossa, the anterior clinoid process, the sella turcica, which is ballooned, and the dorsum celli, okay? And here, if you look closely, there is calcification in the suprasellar area. This is the area where a craniopharyngioma arises from, and then when it enlarges, it goes upwards and downwards to encroach on the sella turcica, leading to erosion of the sella turcica. Okay? And this is a coronal MRI, coronal, like that, T1 weighted image because the CSF appears black, showing a large cyst. You see, here they have given IV contrast, enhancing the rims or the shell of this cyst, the white structure, okay? With mild hydrocephalus, you see the cyst has encroached upwards, causing obstructive hydrocephalus, okay? Anything not clear so far?
لا يا دكتور تمام.
Okay, this is an axial like that, cut like that, CTs on the sella. Bone appears white. Calcification also appears white, like here. CSF appears white, and the brain matter appears grayish in color. So here you can see a very large calcified cystic structure in the suprasellar region with hydrocephalus. All the ventricles are dilated with CSF. Okay? Okay, so this concludes the first part of today's presentation. Any questions so far? Anything that is not clear?
No.
Are you tired, or shall we continue?
لا تمام continue.
Okay. This is only the voice of who? Who was speaking? I didn't see. Who was speaking? Who said to
أنا
continue?
نجوى.
Doctora Nagwa. Okay. What about the rest of you? The rest of you, I don't hear any other voices. Ah,
Yes, doctor, we can continue.
okay. Okay. Type. Let's continue. Just tell me whenever you see my slides, okay? Just a second. Can you see my slides now? Huh?
يا دكتور.
Are they small
Yes,
or in
doctor.
slideshow?
slideshow.
No slideshow.
Moving or fixed?
Moving.
Okay, great. So the intended learning outcomes of this lecture are the following. You will be able to list the symptoms and signs of hypothyroidism, and you will be able to detect the atypical presentation of hypothyroidism in children, young women, and elderly patients. And you will be able to enumerate the symptoms and signs of hyperthyroidism. You will be able to diagnose the presentation of hyperthyroidism according to etiology. You will be able to detect the atypical presentation of hyperthyroidism in children and elderly. You will be able to differentiate the type of goiter in the different causes of hyperthyroidism. You will be able to diagnose the different eye signs in Graves' disease. And you will be able to describe the different methods of detection of exophthalmos, very important. You will be able to differentiate the different types of thyroid nodules, and you will be able to describe the different imaging techniques in thyroid diseases, namely thyroid ultrasound and thyroid scintigraphy. Okay, now let's come to hypothyroidism. As you all know, the clinical features, they include symptoms or the complaints of the patient and the signs. Symptoms. The patient will complain feeling tired all the time. She has malaise, as if she's sick. She has weight gain, and this bothers female patients a lot. Okay. Some of them may complain of anorexia or loss of appetite, cold intolerance. This is very obvious. The patient will come in the middle of summer wearing all the possible clothes she has at home and still feeling cold, while the rest of the patients in the ward, they are feeling hot and they want to open the windows or open the fan. Okay. She will complain of poor memory. She will complain of change in appearance. Look at my face, doctor. Okay, yes, I can see your face. What about your face? Tell me what is wrong with it. Ask the patient to describe her face for you. She will tell you, you see, I look very pale in color. My features are, facial features became coarse, but of course, unlike those in acromegaly that I have shown you earlier. I will show you pictures later on. Okay? She may complain. I keep telling she because most patients with hypothyroidism are females. Okay, so the patient will complain that she's depressed all the time, or if she's not, doesn't have any insight, the husband or the children, they will take the patient to the psychiatrist, complaining that their mother or the spouse is, his wife is depressed. Okay, if the patient is a male, he will complain of poor libido with impotence. Why do you think? Who can tell me? Who can tell me? Are you still there? Can you hear me?
hypothyroidism.
Yeah, the patient is hypothyroid. Why? The question is, why is there impotence in a male with primary hypothyroidism?
ال TSH وال TRH هيعلى وال TRH بيعمل stimulation prolactin
Yes,
أو inhibition
yes.
dopamine.
Okay, very good, very good. So because in primary hypothyroidism, particularly if severe and neglected, TSH will rise. In addition, TRH will also rise from the hypothalamus, and TRH is known to increase both TSH secretion and prolactin secretion from the anterior pituitary gland. Okay, so hyperprolactinemia can be found in primary hypothyroidism. Okay, leading to galactorrhea in female patients as well as impotence in male patients. Okay, you may find goiter in a patient with hypothyroidism, but mind you, goiter is present in only some causes of hypothyroidism. Who can tell me which causes these are? Not all cases of hypothyroidism have a goiter, but which cases have a goiter? Who can tell me?
الهاشيموتو
Yes, Hashimoto's
والأيودين
thyroiditis.
deficiency
Yes. What else?
البوست اللي هو
Dyshormonogenesis. Dyshormonogenesis. This is a rare genetic disorder which can be familial, like in Pendred syndrome. Pendred syndrome is a familial form of dyshormonogenesis in which all family members suffer from hypothyroidism with a huge goiter, all right? And they have, in addition, nerve deafness, okay? So these are the three causes of hypothyroidism associated with a goiter. But the rest of the causes, you will not find any goiter, okay? And the patient will also complain of having puffy eyes. She will complain, a female patient, again, she will complain of all the cosmetic disturbances, okay, in her appearance. Dry, brittle, and unmanageable hair. Look at my hair, doctor. Okay, what is wrong with your hair? You see, it's very dry and brittle, بيتقصف, and it falls off, okay? I lost a lot of hair from my scalp. Dry, coarse skin all over the body, not only on the hands or on the face. Huh? She will tell you, I bring all types of creams. I even use Vaseline. I use Dove cream bar in order to moisturize my skin, but nevertheless, it is very dry and coarse. Okay? The patient will complain of arthralgia, painful joints, myalgia, painful muscles. She will also complain of muscle weakness, like in acromegaly, okay? The same, yani the shoulder and the pelvic girdle muscles, proximal muscle weakness. She will complain of constipation. In order to know whether she has constipation or not, you need to know what her normal bowel habits are. So if she tells you, I used to defecate once every day, but now I defecate once every 10 days using a laxative, this is definitely constipation. And she also strains at defecation. Okay? Women complain of menorrhagia or oligomenorrhea. Okay? In addition, she will have psychosis, which will bring her right away to the psychiatrist. She may have deafness, even if she is not having Pendred syndrome. Okay? And finally, coma. This is the worst presentation ever of a hypothyroid patient, myxedema coma, because it is one of the very dangerous endocrine emergencies, as I have told you before in the lecture, and the mortality rate is very high. Okay? Now let's look at the signs. Any problems so far regarding the symptoms of hypothyroidism?
No.
Okay. Now regarding the signs, mental slowness, very evident. I will tell you about the prototype of a hypothyroid patient I have seen during my residency. She had impending myxedema coma. She was a 60-year-old female patient named Zainab. Okay, she was brought on a wheelchair by her daughter to the ER, and she was sleeping. She was putting her head on the chest like that and sleeping. So I asked the daughter, what is wrong with your mother? She's very sick, like you can see. Yes, I know what is wrong with her, Alf Salama. She told me, let me put my charger before. My laptop goes off. Can you still hear me?
Yes, doctor.
Okay, so she told me she's sleeping all the time like that. And at home, if she's sitting on the sofa, she keeps sitting the same position without moving, like a statue. Poverty of movement. See? Poverty of movement. And by night, when she goes to sleep, she sleeps on her right side. She doesn't turn in bed like all of us. She keeps lying on the right side till the morning, like like a log. Okay? Okay, type. Of course, psychosis and dementia I couldn't check for because the patient was asleep. Ataxia also, the patient was sitting on the wheelchair, so I couldn't examine her gait. Okay, so I tried talking to the patient. اسمك ايه يا حاجة? The daughter immediately, no, raise your voice, please, doctor. My mother is deaf. She doesn't hear. When did she become deaf? Ever since she became sick. So I put my mouth near the patient's ear and I raised my voice a bit. اسمك ايه يا حاجة? Huh? Take notice of what I will tell you. The patient, as if she was deeply asleep. Imagine you are deeply asleep and somebody wakens you suddenly from sleep. How will you feel? You will feel disoriented. You will not be able to look at who's ever talking to you. As if you hear him or her from a very long distance. Okay, this is what happened with Hagga Zainab. She took a lot of time opening her eyes and she didn't look at me. She looked anywhere else. And then she told me after maybe 5 minutes, listen, Zainab. And she fell asleep again. So I noticed the voice was harsh and deep. So I asked the daughter, is your mom's voice normal that way? She told me, no, of course not. It became deeper ever since she got sick. Okay. And the patient, Hagga Zainab, she had periorbital puffiness and she was obese and she was even swollen all over the body, not only over the face, over the hands, the legs, the abdomen. She was even admitted for a very silly cause, ascites for investigation. Instead of writing impending myxedema coma, she was diagnosed as having ascites for investigation. Okay? She didn't have a goiter. This is why I put it between brackets. And she had very dry and thin hair, and she had dry skin all over the body with loss of the eyebrows, like I'm going to show you in the pictures. But then peaches and cream complexion, this I couldn't verify because she was dark in color. Her skin was dark in color. I will tell you in a minute what peaches and cream complexion is. Okay? Now, this is a picture of a female patient with gross hypothyroidism. You notice the face is swollen. She has a peaches and cream complexion. What are peaches? Who can tell me? Peaches. What are peaches?
Oh,
Yes. الخوخ. What color are peaches?
peachy.
لا مش peachy. Peachy. Nice color. What is peachy?
اللي هو على سيمون كده.
يعني برضو what color?
Light orange خالص.
Yes, orange yellow in color. Orange yellow in color. This is actually the color of this lady. You see the cheeks? They as if she has peaches and cream complexion. So the Caucasians, they have a fair skin, and so whenever they are healthy, their skin appears pink in color. Okay, but when they develop hypothyroidism, like this lady, they develop hypercarotenemia, increased carotene in blood. Why is carotene increased in blood in hypothyroidism? Who can tell me? Who can tell me? For the sake of time, if you don't know, just tell me I don't know. There is nothing wrong in admitting that you don't know.
I don't know.
Okay.